Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission to provide medical professionals with the resources they need to learn from each other and in doing so, improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics including multidisciplinary approaches to patient care and new innovations in medical technology. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org. Good afternoon, everyone, and welcome back to another episode of the Practice of Medicine podcast. I'm your host, Dylan Stevenson, and today we're going to be joined by Dr. Philip Hartman. Dr. Hartman was once the president of the Southern Medical Association, and today we're going to be discussing the COVID vaccine, and mainly his opinions on the vaccine and what it has to bring for the individual and the community at large. Thank you for joining us today, Dr. Hartman. How are you doing?
I'm doing well. Thank you, Dylan. How are you doing?
I'm doing well. Thank you for asking. So my first question is going to be, how does the COVID vaccine work and how was it able to be made so quickly?
Okay. So if I could give a little bit of background before we do that, just to let our listeners know, since there are tons of sources of information out there on this, and they might be thinking, well, why am I listening to this particular family doctor on it? As you mentioned, I'm a former president of the Southern Medical Association. I'm also an adjunct professor at multiple medical schools and a clerkship site coordinator for the University of Kentucky's College of Medicine, Northern Kentucky branch. But really, what makes me an adequate speaker on this topic goes back significantly further than that. Back in 2005 through 2007, I was working in a cell biology lab building, splicing together a DNA sequence to build fusion proteins for cellular transport. So that gives me a little bit of background on the topic. I presented on that work at the American Society of Cell Biology and the American Cancer Society's annual meetings. So as I give some of this where it came from, how it came so quickly, I am relying in part on past experience. And my past experience actually made me ask the exact same questions. So as to where did it come from? How did it come so quickly? I get asked that one all the time. And I'll tell you that back in 2005, when we were trying to build that DNA sequence to build a fusion protein, doing so required using specific enzymes that would cut certain DNA sequences on two different strands of DNA. And then putting those DNA sequences together with different enzymes that would glue them back together in an attempt to create the right strand. Once we did that, we'd run them through a gel they'd go different distances based on their length to find the one that's the approximate length that we expect the sequence we want to measure. At that point, we'd have to cut that part of the gel out, we'd purify it down. And each time we did these things, once we thought we had what we wanted, we had to send it off, and it took weeks to sequence to tell us what we'd actually made. And then we'd use it to make the protein, and it'd take weeks to break that down and make sure we'd made what we thought we made. The reason I'm telling you all of this is that was the technology then. So when people say, oh my gosh, it's been this long and we haven't found cures for X, Y, and Z, or we haven't made a vaccination against this other thing, it was only very recently that the technology existed to make something quickly. So let's talk about that technology. This was not built from the ground up. A lot of people say, how in the world did they put this together from the ground up? This is like if you've got something you're trying to take apart and you can't find the right tool for it. You walk into your neighbor's garage, you look around, and you say, ooh, I bet that tool could turn this screw. That's what happened. So we were poised with a problem. We looked at this and said, wait a minute. Over here, we've got people doing cancer research on how to tag cells for destruction by putting mRNA into them to produce a specific protein that they would not have otherwise produced. So this wasn't a reinvent the wheel. This was look around and say, ooh, I bet that tool could work for what I need to solve. Now, the way that tool works is our cell membranes are surrounded by a lipid layer. So that's fat. Now, anybody who's ever been cooking, for example, and poured fat in with water knows that they keep apart. Oil and water separate. That's even the old axiom of we're as different as oil and water. Now, anybody who's been cooking and has poured oil into another oil knows that they do not separate. They go in together. So this vaccine, the Pfizer and the Moderna vaccines that are the newest technology being used, they are a little fat ball that can be absorbed into the fat of a cell membrane. So we call it translocation when you can move something from outside a cell to inside. So they can translocate their contents into the cell membrane. So that's step one. We've got a tool that can do that. Well, the contents in this specific vaccine are mRNA. mRNA, or messenger ribonucleic acid, is a blueprint for protein. Our body's got mRNA in every cell. So this is not something your body hasn't seen. You you see that mRNA and the body knows right what to do with it. We have these things called ribosomes. They jump on the mRNA, they run down it in sort of a train fashion, producing proteins. So that's the technology of it. Oh, and the important thing, so I have people say to me all the time, okay, so then I have this forever. No, you don't. The body is efficient, the body is a good recycler. So that mRNA translocates into the cell. The cell goes, ooh, look, a blueprint for a protein. It runs down the protein with ribosomes, or runs down the mRNA with ribosomes, builds its proteins, and when it's done running down that, it breaks up the RNA into its components so it can build new RNA for whatever protein your cell was poised to make next from the instructions within the nucleus of your own cell and your own DNA. I had a patient ask about that, and they said, well, so it's going to make another immune response. And while it could certainly do that if that's what your body wants to do, mRNA for an immune response, mRNA to the proteins that we wanted to make for this particular immune response is not specific to an immune response, is not specific to COVID-19 in any way once it's broken apart, any more than when you eat a hamburger, your body doesn't use that to put beef somewhere on your body. So we break things apart to make the things we want to make next. We break them down to their finest components. So to back that up again, the little lipid ball hits your cell membrane. It translocates some mRNA, which is a blueprint for protein. Your body runs across that blueprint, makes the protein, degrades the mRNA. Okay, the next step is that protein that has been expressed gets identified by our immune system. Now, Pfizer and Moderna are both two-shot deals. Remember, I said you only make it for a very short time. So the first time your body sees that, it looks at it and goes, hey, wait a minute, have I seen you before? Should you be here? And then to personify the cell, let's say it has 3 to 4 weeks to think about it. Now, during that time, the body is recognizing that what it first saw should, in fact, not be there. That way, when it sees it the second time, it can initiate an even stronger immune response that will last for longer that says, hey, I know you shouldn't be here. Rallies up the troops, gets them ready, fights it off. That's why people get more symptoms typically with their second shot than their first. But again, it's a short lived response. Even the people with bad symptoms typically have about 48 hours or less worth of bad symptoms. And of note, if you get this and get upper respiratory symptoms, it's not from your vaccine. You need to call your doctor. The vaccine will only cause the systemic, the whole body symptoms, the body aches, joint pain, arm soreness, local site reactions, those sorts of things, potentially fevers. But again, even if you get them, they are short lived.
Well, let me just say, I don't think anyone has any more concerns about why we have you on this podcast because you just explained that. And obviously, you can tell that you're an expert in that field. So thank you for that. So I've seen on the news, and a lot of people's main concern is that it was just made so quickly. How was it able to be made so quickly and brought to the market?
Absolutely. So I already said that the technology that the vaccine was made from was borrowed, not created. Um, and I mentioned how long it used to take to build a sequence to make a protein. Well, now we've got a fancy new method that is basically similar to almost digitally printing your protein. It lays down the nucleic acids in the order you want it. So if I worked in the same lab today that I worked in 2005, instead of spending an entire year to create a fusion protein, we would have paid a company, they would have created the sequence, sent it to us, and we would have gone on to the next step of the process. So that's what happened here. This is probably the most specific medicine we've ever had. Um, a lot of people are aware that many of our medications were found by finding a substance and saying, "Ooh, I wonder how that would react with this disease," testing it in an in vitro model and then an in-person model, and seeing what happened. This vaccine's different. We did the reverse. We looked at the actual thing we wanted to learn to initiate an immune response. And for those who've asked, is this a vaccine? Yes, it is. A vaccine is a treatment given to initiate an immune response to protect against future infection. So we looked at the infection we wanted to protect against and we said, what protein does this always have that we could get at the very beginning of infection? And that's where that spike protein you've heard a lot about has come in. So we said, you know what? It's all got this spike protein. We then said, okay, what's the amino acid sequence of the spike protein and what's the nucleic acid sequence to make that? So this was very intentional. There are very few ingredients in this vaccine because of that. So it's the most specific medicine. It's kind of akin to when we use monoclonal antibodies for cancer. So very specific. And they took that, they made the vaccine, and unlike, say, our flu shot, that's an entirely different process and an entirely different virus, by the way, too. The flu is a scrambled, it's like building a truck. You get to choose a cab, choose a bed size, and you could make any combination you want to. But for this one, instead of having to grow it in an egg to create the protein, purify the protein, deliver the protein, our body builds the protein. So that's a quicker process to manufacture, and that got it to studies. Now, typically, when you study a drug, the drug company would like to fail cheap and fail quickly if they have an ineffective drug. To do that, you do a small study to prove that it is safe to use. They still did that with these vaccines. They did a small study that said, hey, were all the people who received this okay? Yes, they were. Then you do a small study to say that you think it might work. Well, why do you do that? Because small studies are cheaper than large studies. And if your drug doesn't work, you don't want to have lost $1 to $3 billion on something that's never going to make you a penny. Well, this one was different because we, the taxpayers, through our federal government, ponied up the money for this. They gave these companies between $1 and $3 billion apiece and said, I don't care if you fail or not, you get to keep the money. So they had nothing to lose, and they went directly to the big study that could show statistical significance. This is normally what would have followed the small study. The analogy I like to use for this is if I set you in a casino and said, hey, Dylan, I want you to play blackjack. You said, okay, cool. I know the rules of blackjack. I know the probabilities I can do this. And I said, yeah, but I want to see how many times you get 21. You'd say, well, I'll get it sometimes, but sometimes I'll win with 16 or 18, depending on what the dealer has, depending on what I have. But I said, no, 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 no. I just want you to get 21. You'd say, Philip, that doesn't make any sense. I'm going to lose all my money. And if I said, Dylan, here's a big cup of house chips. I don't care if you lose your money or not. I just want to know how many times you get 21 in an hour. You'd say, hey, dealer, deal in every seat at this table for me. Hit on anything that is 20 or lower. Well, that's what the companies did. They said, hey, we're playing with house money. We're going to go straight to a 30,000 person trial so that we can hit statistical significance quicker and see if this really works quicker. Now, even with that in place, we still didn't know it could come out as quickly as it did, but human nature kicked in. So, one, we've got a highly contagious virus, and it wasn't really ripping through the population at the rate that it would have taken to get this vaccine to market, but people got sick of being apart. People got sick of wearing their masks. People got sick of not going where they wanted to go, and restrictions started to loosen. And we saw that big wave of infections that happened last summer. Well, as unfortunate as the big wave was, that's exactly what it took to have enough people infected between the people who had placebo and had the actual vaccine for the companies to look at this and say, hey, we're ready to unblind this study, because the companies didn't know between the infected people and the uninfected people who had gotten placebo shots and who had gotten vaccine shots. But they hit a high enough number of infections that they could unblind that study, look at it, and say, ooh, this thing really works. And that's what brought it to market so quickly. A combination of newer technology that's more efficient at producing a product, a great source of funding that was not no longer reliant upon market profitability, but provided the profits up front, a highly infectious virus, and people with cabin fever. So you combine that all together, and that's what brought this to market as quickly as it got to market.
Thank you for answering that question. And I really like the way you broke it down, and it seemed really easy and helped me understand more. How do you think the COVID vaccine will benefit the individual and the community at large?
Honestly, and this might sound grandiose, but I think that the vaccine for the individual and the community at large means that we now have the tool in hand to end this pandemic. I'll let that sink in a second. So I've heard people say, oh, the virus will never go away. The virus will always be here. That's not necessarily a true statement. Smallpox was once, the scourge of the earth. It took out tons of people. It was a pandemic that lasted a very, very long time. But through a very rudimentary vaccine, Dylan, you and I never got vaccinated against smallpox. Our listeners over 50 probably have a scar on their arm from when they got vaccinated, but my kids will never see or hear about smallpox, barring a biological warfare scenario. Um, and this was an extremely contagious and extremely lethal disease. But because the vaccine was widely adopted across the world, because people, at the time it was on ships, because people took ships to areas of the world that couldn't create their own vaccine and didn't have the technology and the medical professionals to distribute it, and distributed them in countries that weren't their own, smallpox was eradicated. Polio nearly met the same fate. We still see that predominantly in underdeveloped countries, but there are so many diseases that were common. Shoot, chicken pox is extremely uncommon now. And there's virtually no one who is my age or even 6 years younger than me or older who didn't have chicken pox. So, an effective vaccine means stopping the pandemic. The trouble with that is the effective vaccine has to be quickly distributed, because a virus that's allowed to spread is allowed to mutate. And as of right now, none of the mutations have shown to completely defeat the vaccine. But if we don't roll the vaccine out quickly enough, that could happen. Now, the good news is, like I mentioned earlier, that technology is faster than it used to be. So the company said a few weeks ago that in 6 weeks, they could completely retool the Pfizer or Moderna shots to cover new variants. So we could still get ahead of this. We can still win, even if the virus mutates faster this time than it takes us to vaccinate enough people to stop spreading it. But it's kind of like we're trying to play a game of hot potato, and we're passing the ball around, but I'm also handing out ice cream cones. If you've got ice cream cones in your hands, you can't catch the ball. Well, we can't really play hot potato anymore if enough of the people standing in the room are holding ice cream cones. That's the vaccinated people. And as far as the individual, well, you have an extremely low risk of contracting the disease at all, and you have an almost zero risk of dying of the disease or ending up hospitalized with it, with any of the vaccines currently available and any of the vaccines currently seeking approval. So Worst case scenario, we turn this into just another coronavirus like the common cold when it no longer causes hospitalization or death. Best case scenario, we get rid of it altogether. And I know there's been some question. I've had patients say to me, why would I get this if I still have to wear a mask and if I'm still able to spread the disease? So, as far as what does it mean to society and the individual? Well, that is an issue that the news has had with presentation of medical jargon. When we say could, it's not the same as can. It's there is the potential that it is possible, which is different than saying you can do this. The analogy I use here is could I run a 5 minute mile? Dylan, could I run a 5 minute mile?
Now, with you, I probably could say, yeah, me, yeah, no.
So I could. It is possible if you've never timed me running a mile, it's humanly possible to run a 5 minute mile. And it's possible that I could do so. Now, at the same time, if you timed me and the best I could pull off is 6 minutes and 30 seconds, would you say that I can run a 5 minute mile?
In layman's terms, I would say no, but who's to say you couldn't do it down the road?
Sure, absolutely. So if you timed me over and over and and habitually I never broke 6 minutes and 30 seconds, then you'd be able to say he cannot run a 5 minute mile. So in scientific speak, when we say something could happen, oftentimes what we mean is I don't have enough evidence to prove that it could not. When we say something can happen, what we're saying is, hey, if you do this, this will happen potentially. So there's a difference between those. And the only scientific wording of this I've ever heard is that a person could potentially still pass it. Now, if a vaccine is 95% effective at blocking disease altogether, then that is an incredibly low could. What we're seeing statistically now, and what we're seeing in countries that have large numbers of vaccinations, such as Israel, does not support that individuals who are vaccinated are spreading this virus. And that's consistent with how we treat other vaccines. If your employer requires a flu shot to work in the hospital you work in, they're saying, I don't believe that you can spread the flu as readily if you have this shot as if you don't. If schools require vaccination against measles, mumps, rubella, chickenpox, polio, diphtheria, tetanus, pertussis, I'm sure I'm leaving some out, prior to going to school, meningitis at some age, it's because they believe that you are less likely to transmit these illnesses. Not all of those are viruses if you have been vaccinated. So the way in which we treat other vaccines implies that we believe that an individual who is exposed for a first time can build immunity quicker than they can become infectious. And that's really the question. Can I spread it after I'm vaccinated? Broken into scientific terms, what you're really asking is, can I take the IgG antibodies that my body produces for immunologic memory, and can I retrain my body to make IgA antibodies, which are the ones that would cover the virus on a mucous membrane, like your nose or your eyes or your mouth or your gut? Can I make those quicker than the virus can double to an amount at which I could spread it? And while we don't have full data on this yet, at least on the Pfizer and Moderna, I haven't heard as much information on the others, but at least on those two, the implication of early data suggests that you probably can make those IgA antibodies quicker than you become infectious. So I tell them, you know what? It doesn't mean you can spread it. We don't know that you can spread it once you've had it. And even if you could, it would be the first time you're exposed and only until you make those IgA antibodies, because just like we use antibodies to treat patients who have this illness, my antibodies would cover a virus in a way that it's non-infectious for you, the same way that your antibodies would cover them for you. So what it means to the individual is you've got next to a 0% chance of being hospitalized for this illness or of dying of it. It also means that you have a dramatically reduced if not altogether gone, risk of giving this to someone else who would then go on to die of it. For now, we still have masks in public. Part of that is we don't have enough of the population fully vaccinated. And part of it is we don't want to cause fights by having people walk in places without their mask on when they know they're vaccinated, but the person they're talking to doesn't. But the CDC has already come out and said if you are a small group of vaccinated individuals, you can hang out indoors without distancing, without masks, and with low risk individuals present, which in layman's terms means you can bring your kids. So that's worth noting. They have adjusted their rhetoric a little bit to say, hey, it looks like this vaccine really makes you pretty safe, and it makes you safe enough that if somebody around you is unlikely to die if they contracted this, it's okay to have them around too if the rest of you are vaccinated.
Yeah, and I totally get that. It's just kind of like the flu shot. 9 times out of 10, I'm going to be perfectly healthy and fine, but there's going to be that one time where I still develop the flu. The flu shot is not a cure, it just helps you with having a less chance of catching the flu.
And actually, that's something I'd like to address too, because I kind of mentioned the truck model for flus. Um, I've had a lot of people say to me, "Isn't this the same as the flu?" And the short answer is no. They are both viruses, but Ebola is a virus. Um, HIV is a virus. Rabies is a virus. I don't think any of us would say, oh, I got the flu, I felt bad. And a friend goes, I got Ebola. And we'd go, same thing. Right. So just because something are both viruses is kind of like saying, well, my mechanic's a person and I'm a person. So if my patient's sick, they might as well just go see my mechanic. No, just like if their car's broken, they shouldn't come see me. Um, the flu is also a little bit unique in that it transfers between people and animals and between people and people. And it's almost like a Lego set to build trucks. So if I gave you 6 different cabs and 6 different beds and said, hey, Dylan, build a truck, I only know how to identify one of them. Well, my probability of knowing the truck that you build is actually rather low. So when we make a flu shot, we look at the other hemisphere that has a reverse flu season. We see what has gone around and we try and predict what combinations of trucks you're likely to build. Now that makes it really tricky to get it just right. In this case, it's still just one virus. It's not a combination of trucks. It has little mutations that have happened, but none of them have been as dramatic as an H1N1 is to an H2N3. The variations in flu are more dramatic than in this. Though I do think, as much as I say, oh, the flu shot's different than this shot, I do think it's likely that at some point in the future we'll start building our flu shots this way. Because if you can retool this in 6 weeks to cover things you weren't previously covering, that means those years that we've gone, oh, shoot, we missed the mark with this flu shot. We could say, okay, but in 6 weeks we'll have the right one. And that's kind of exciting.
Now, let me tell you, back during the swine flu epidemic back in 2010, I believe it was, I got the regular flu. I got tested, didn't have swine flu, and I have never had that kind of pain in my life. I missed a full week of school, and I never missed school. Had to miss a football game, never missed a football game a day in my life, and I would not wish that on my worst enemy. That was just the worst pain I have ever experienced in my life.
So some people will get this and say, oh my gosh, I've never felt more like death in my life. Some people will get it and hardly have any response. And we haven't found a wonderful rhyme or reason on that. We found the typical things, which is unhealthy people are more likely to die of something than healthy people, and older people are more likely to die of something than younger people. But beyond that, and children are much more likely to be completely asymptomatic than this. Beyond that, we have these random one offs that, in and of themselves, are a decent reason to consider this vaccine. I've known patients who were, avid runners before this and healthy, relatively young people who can't climb 2 flights of stairs several months after getting over COVID. I've got other patients whose heart rates have remained elevated months after having COVID, and they're working with electrophysiologists trying to figure out how to get this back under control and taking new medications they never took before and avoiding physical activity because they just can't do it without their heart rate shooting way up. So the long-term organ effects, or at least we'll call it short long-term, since it obviously hasn't been around for years and years, in certain people appear to be pretty dramatic. The reason that's important is one question I'm frequently asked about this vaccine is, what are the long-term effects of this vaccine? Or I'll have people who say, I'm not going to get it until I know the long-term effects. Well, that's a bit of a logical fallacy there. It's what we would have called they're creating what we would have called a false dichotomy in logic and knowledge. So what that is when you pretend like there are only two options and you compare them that way. Well, in this case, there are three options, and the two most likely options are not the options they're considering. So the three options are I get the vaccine and don't get COVID and deal with the side effects of the vaccine. Option two, that they consider as the only option, is I stay perfectly healthy and get exposed to nothing. That's the fallacy there. This is contagious enough that unless everyone else decides to take care of you by getting their vaccines and preventing you from encountering it, your more realistic choice is I get the vaccine and get whatever side effects might come with it, or I get the illness and get whatever side effects or long term effects might come from it. That's a big difference. It's more akin to when I have a patient who's 350 pounds and we talk about bariatric surgery and they say, ooh, I don't know that I want the risk of that surgery. And I have to back things up a step and say, when we look at the risks of this surgery, we can't compare it to no risk. We have to compare it to the risk of remaining 350 pounds. So that's when people say to me, well, I want to know the long term effects of this vaccine before I get it. I tell them, you're absolutely right. It has not been out long enough that we know the long term effects of it. Neither has the virus. We can't tell you what the virus looks like 5 years down the road either. But I can tell you what the virus looks like 9 months down the road for some patients. And I can tell you that for some of them, it looks like a significant decrease in quality of life. I can tell you for some of them, it looks like end of life. So, what we're comparing here is the potential for long term side effects of the vaccine to the potential side effects long term of having contracted COVID. Now, short term, yep, some people get COVID and get no symptoms. And some people get the vaccine and get no symptoms. Some people get the vaccine and feel like death. But generally, the worst I've heard people say that they felt, have been the people who felt that way for about 6 hours. I could feel like death for 6 hours if all it meant is that major league sporting events would open back up. Um, but the people who felt kind of lousy, it's generally better within 48 hours of beginning to feel kind of lousy after the vaccine. So that's worth considering. And there is nothing of interest that you would encounter by getting the vaccine that you won't encounter at higher levels by getting COVID. So when people say, I mean, there was that article that went around that's completely without validation that said that COVID would result in women being infertile, or sorry, that the vaccine would result in women being infertile. Well, if antibodies to the spike protein, even if we humor that and say antibodies to the spike protein could do that, you will get a significantly larger number of antibodies to the spike protein, as well as antibodies to numerous other antigens if you get infected with COVID. So that's worth considering. You're not looking at, do I get the vaccine and make some antibodies and have protection that's almost 100% against hospitalization for COVID and death by COVID? Or do I get the disease and mount whatever immune response to whichever components my body chooses? Um, if in fact antibodies to spike protein cause infertility, then based upon the percentage of people who've had this disease, we should expect a significant drop in our population in coming years. But again, there's no evidence that that's the case. And even if it were, you get a smaller number of antibodies by getting the vaccine than by getting the disease.
So, quick sidebar question off this. My parents both got COVID-19 at the same exact time. My dad works in the school system, and we feel like he somehow got it through that. And then my mom, obviously living with my dad, caught COVID-19. My dad's symptoms were very mild. He did feel bad and stuff, but it wasn't near as bad as what my mom had. There was days we thought, you know, are we prepared for if she does happen to, God forbid, pass away or anything like that? Because she was really bad for a couple of days. And thankfully, they both recovered and everything like that. So how do you take people's misconceptions of COVID-19 when you have such a various symptoms between person to person?
I think the biggest one that I have heard people get is that it's not that dangerous. That they say, oh, well, because so many people do really well, it's not that dangerous. I had one person say, it's like 1% of people who die. That's not that dangerous. I have an analogy for that too. Listeners, you probably caught on already. I frequently speak in analogies. I do so in part because it took 11 years of post high school training to get to the point where I was allowed to analyze research papers I read on my own. So if I want to start from square one and explain everything, it can be really difficult to do it in a way that's palatable. But people tend to relate to simpler analogies better. So I go with that. Um, the analogy I use for that one, and my own parents asked me that because I had some elderly family members who got this and did fine. My parents said, well, if that happened, then how is this such a big deal? And I said, well, we're in America, which is the most gun owning country, as far as I know. And, uh, and there are people who have small children in their house who frequently keep a loaded handgun tucked under a mattress or in a bedside table. In fact, there are tons of people who do that daily and have never had a child injured in their home. Unfortunately, there are also many children each year who are killed by guns that were left inadequately secured. So just because your neighbor might keep a loaded gun under their mattress and their kid made it all the way to 16 and never got a hold of it and never got hurt by it, doesn't make that a good idea to do. So when people say, oh, well, it's not that dangerous, I know somebody who is 80 who got it and got better. Fabulous. I'm so happy that the person you know who is 80 got it and got better. However, if we gave it to all of the 80-year-olds, that would not be the outcome. So we need to keep in mind that just because something happened, it's kind of like if you've got a friend who loves to drive fast and they say, I have my car up to 160 on the interstate and I was fine. Okay, I'm glad they were fine. That does not make that a safe activity. So in medical speak, when we talk about levels of evidence, we have various levels. They begin with anecdotal evidence, which is I had a patient once and this happened. Then they go to professional opinion, which is, you know what, this hasn't been studied, but we talked to the experts and this is what they think. Then they go to small non-randomized trials or retrospective analysis where they say, hey, we didn't test this, but we looked back at all the data we could find and this is what we think, to all the way up to multi-center systemic reviews of placebo-controlled blinded studies. This is why when people say, hey, I did my research and this doesn't look that bad, well, the fact that they found a doctor somewhere who said something is not nearly as strong as the actual studies that were done that were blinded and controlled and analyzed and available for all of us to see, which is fabulous. The transparency on these vaccines has been better than anything I've ever seen come out new in medicine. But I guess what I'd say, Dylan, to answer your question is there are the random one-offs. We shouldn't take the random one-offs to mean that it's not dangerous. Just because you have a friend who always kept a handgun under their mattress and their kids didn't get killed by it doesn't mean it's safe to have young kids in your house and a loaded handgun under your mattress.
Very well put, sir. And so now I'm going to move on to my next question, which is obviously you received the vaccine or you would not even be recording this podcast with us. So, how are you feeling today? And as a result of having been vaccinated, are you going to do things differently, whether it's at home or at the office?
Yep, I'd love to answer both of those. So I did receive the vaccine. I was blessed to be able to receive it early on. Um, After my first vaccine, I felt like I'd been punched in the arm really hard. It's like back when you're on a family vacation as a little kid and you're sitting on the bench seat of your van, your brother decides you're too close to him and just nails you in the arm. It felt like that. I probably couldn't take my arm above 45 degrees for maybe 36 hours, beginning about 16 hours after my shot. So I had that. And then for the next week or two, I could poke around and find the spot where I got it. Obviously, that's an inconvenience. It's not a life changing event. When I went to get my second shot, they said, because I know the pharmacist who has given us our information on it, she looked at me and said, are you off tomorrow? And I said, no, I have 34 patients scheduled tomorrow. She said, oh, you might not want to do that. Well, lucky for me, I had almost no reaction at all to my second shot. Now, I did take one ibuprofen and one Tylenol that morning, that night, and the morning of my next day because I thought, I don't want to chance it. But my arm didn't even get sore from my second shot. So the reactions are highly variable. I was one of the lucky ones. Mine were so minimal that if nobody ever got reactions worse than mine, I don't think we'd hear anybody complain about their side effects. Um, what was the second part of your question? Oh, what do I do differently?
Yes.
So from February of last year through vaccination, there are certain things that I hadn't done, some of which hadn't been the best for my health. Now, while I am relatively young, healthy, unlikely to have died of COVID if I got it, as a family practice doctor, I take care of high risk patients every day. So I had to consider not just how my actions might affect me, but rather the potential that my actions could create an unsafe environment for the patients I take care of. So from February of last year until after I was fully immunized, I had not eaten in a restaurant. From maybe March of last year when it first started showing up in our area, I had not been into the gym. And when I go to the gym, all I do is go in and swim. So it's not like I'm hanging around with other people. But I waited until after I was past my period at which I should be immune. And I started going into swim again. I've been doing it 6 days a week since I was immunized because being in shape is important. Being healthy is important. Taking care of yourself is important. And now I've got significant protection on board to think that I might be able to do this without being of risk to my patients. Um, Also, my wife, for working with the schools, has gotten to get her vaccine. So once she was fully immunized, one of the first things we did is made reservations to go out and have a date. We hadn't had a date in a year outside of the house. So, and we'd picked up food from restaurants that, um, local restaurants that we wanted to support, ones that we want to make sure stay open. We'd picked up food, but we hadn't actually gone out and sat down in a restaurant. Now, having done that, I was really glad I waited until I was immunized because our population at large doesn't appear to be the best at distancing and mask wearing. So being somewhere without one felt awkward. And we're all going to have to get over that when this is over, that it's going to be different to walk around and be like, whoa, everybody's got faces. My face is out. So I did those two things different. Do I still wear a mask when I'm in stores? Absolutely. Do I still wear a mask in my office? Absolutely. If I'm hanging out with friends or family members who are vaccinated, do I wear a mask? No. That's something I do significantly different is I've gotten to get back together with some friends and family members who I hadn't gotten to be around during this because small groups of vaccinated people can safely get together now.
Great. It's great to see someone who has been vaccinated and you don't see the adverse reactions that people are getting that you see on social media and the news. So that's great to hear. So, how do you think the Biden administration is going to implement strategies for the COVID vaccine? And if you can you give us a quick summary on the difference between the two main vaccines?
Sure. So first of all, as far as where the vaccine strategy goes, knowing the difference between the vaccines and similarities is important. So, first of all of the vaccines that have been improved are phenomenally effective. So, the reason I'd say that is all of them were 100% effective or darn near at preventing hospitalization for and death from COVID 19. Again, like I said earlier, we would have never had a shutdown. There would have never been a significant pandemic if this were just another cold. And that's where that puts this. If nobody dies of it, nobody gets hospitalized by it, then nobody gets excited about it. So, what you can't do is compare the efficacy numbers of one vaccine to another because, say, Johnson and Johnson was studied significantly later with significantly more contagious variants of COVID, and a large portion of the study was done in South Africa, where their highly contagious variant was the variant. So, trying to compare these numbers, because I've heard NPR do it, I've heard the news do it, it drives me nuts when they say Johnson and Johnson is slightly less efficacious at. No, it's not. You can't say that because they're different studies. So, Dylan, it's like if you and I both invented new shoes for basketball, and we said these shoes will make people jump higher. Well, I don't mean to brag, but I used to be an assistant um, basketball coach for the recreational league thing at Burlington Elementary School. So let's say I pool my connections there and I get those elementary students to put on my shoes and jump, and I measure how high they can jump. And you being in Alabama, pull your connections and you get your Roll Tide crew to put them on. So you've got Alabama's basketball team wearing them, and you measure your jumps. You can't compare the height that my fourth and fifth graders jump to the height that your NCAA Division One athletes jump, right? We can't say, oh, your shoes are better because they jump higher. We'd have to put them on the same people and have them jump, or matched people and have them jump. And there's been no head to head research of any of these vaccines. So you can't say which one's better, but you can say all of them are 100% at death and hospitalization. Now, that being said, Johnson & Johnson's a one shot and done deal. That makes it ideal for certain scenarios and populations. So if you want to vaccinate the homeless in your community, if you want to do a church drive, because unfortunately certain communities have not been vaccinated at the same rate. So if you said, we've got an all African American church that wants to do a drive and get as many people vaccinated as they can here in Birmingham, Johnson & Johnson's your go-to. You don't have to find them later. It is just as effective at blocking death by, hospitalization by. It's a great vaccine. And you could get it done in that manner. Same with any transient population. It would be hard to get some people who are just passing through when they talk about doing like migrant workers and stuff. It'd be hard to get them and then get them again 3 or 4 weeks later, but a one shot and done will do that. Likewise, Johnson & Johnson is a less expensive vaccine, so is AstraZeneca. And it only requires refrigeration. We can't just vaccinate our country and pretend like we did something because our people like to travel. So those vaccines are going to be a lot more effective in El Salvador, Honduras, Haiti, Belize, all those places that don't have quite as strong of an infrastructure for medicine and don't necessarily have the ability to keep something at -20 or -80. So what we're likely to see is that sort of vaccine done there. A lot of places are having their health department distribute their Johnson and Johnson vaccines because, again, it's one shot and done. So if you have somebody who's homebound who can't come in to get their shot, you could hit twice as many people with the same number of staff if you only have to get there once. So as far as the Biden administration, what I expect to see, and I think they even announced it, so it's cheating to say I expect to see it, but in the very near future, I expect to see the vaccine open to anyone 16 and older who wants it, for Pfizer, and 18 and older for the other two. But the reason I expect to see that is all the people who are gung ho about getting it have been lining up and getting it. So pretty much all the doctors, all of their family members who are eligible, all of our lawmakers, all of our wealthy people have gone out and gotten this and have gotten their family members to get it, which should be a clue too. If your research is telling you it's not good, the people in the know and the people making the rules have all gotten it. But once all the people who are really vying to get a spot have been able to get one, the best way to get the most people isn't to try and negotiate to get people who are on the fence. It's to get anybody who wants it to get it. And hopefully, as people see their friends and neighbors and family getting this and doing well, they'll say, you know what, I can get it too. And that'll get us there.
Dr. Hartman, I just want to thank you again for joining us today. Dr. Hartman, I just want to thank you again for joining us today. I found this really informative, and I feel like a lot of people who even aren't healthcare professionals can really benefit from this podcast and learn more about the COVID vaccine that they don't see from the news or social media or anything like that. So again, just thank you for being here with us today.
Well, I hope so. And I hope that some people find this who are looking for information on the vaccine, because I know a lot of people have been relying on Google searches or Facebook posts to learn more about this. And I don't know that everybody realizes that Google and Facebook both try to show you what you want to see. So your feed will look incredibly different than somebody who believes differently than you do. And when you Google, you might not get the same results in the same order that I would get. They're tailored for you. And often they become an echo chamber. So if you believe that COVID is a hoax, or if you believe that the vaccine is dangerous, once you click like on enough articles, that's what Facebook will show you. And that's kind of a scary thought. I personally refuse to get my news from anything tailored for me. I tend to listen to the NPR podcasts. They're up first in their news now because everybody hears the same thing. And even if there's a tilt to it, I'd rather hear something with a tilt to it that isn't adjusted for me than hear something that's intentionally trying to tell me what they think I want to hear, because I don't grow by only hearing what I want to hear.
We hope you enjoyed The Practice of Medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcast or subscribe to us on iTunes, Google Play, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org, and thank you for joining us today.